I'd like to thank Milton Leong, Dr. Leong, for inviting me. Thank you so much. And I'm happy to share some of the research that I've done in the past few years about developing a 3D printed bioprosthetic ovary using 3D printing as a strategy for ovarian restoration. So I'm going to begin, though, with talking about some background to kind of set the stage for why this is kind of an area of interest and research that is needed, and why we preserve fertility, especially in pediatric cancer patients. I'm at Lurie Children's Hospital and Northwestern University in Chicago, and so this is something that's kind of at the forefront of what I think about. So the American Society of Clinical Oncology, ASRM, and even the American Academy of Pediatrics recommends that there's at least a discussion for preservation for male and female patients undergoing gonadotoxic treatments. And we do this because infertility is one of the primary concerns of cancer survivors, with 75% of young adults who are childless at the time of diagnosis reporting the desire to have to be a parent in the future. And then a survey that we did in our own hospital, there are parents that want fertility preservation options presented regardless of infertility risk and prognosis. We know that childhood cancer survivors are significantly more likely to be infertile or have difficulty getting pregnant than their siblings, and we can estimate this based on the age at which they receive these gonadotoxic treatments and their diagnosis. And their treatments. And we can do this because of what Wallace and Kelsey had as this model, where a 12-year-old, for example, with radiation that may enter menopause at 19 and a half years old because of the reduction in the ovarian reserve due to this treatment. And this is just the scale and kind of a calculation of when the oocyte reserve may be depleted due to these treatments and at this age. There's also genetic causes for gonadal dysfunction that include Turner syndrome, Fragile X syndrome, and germ cell tumors and galactosemia that could affect a woman's fertility later on in life. So when we think about menopause or reduced fertility, we also have to consider, I think, the sex hormones and how we're going to restore those because of the development of potential disease or disorders that results with the lack of ovarian hormones. And these have really systemic effects and could include decreased bone mass and osteoporosis, decreased muscle mass and high blood pressure, decreased wound healing because of skin laxity, and decreased short and long-term memory. And so we have an ovarian tissue cryopreservation protocol in our clinic that's been approved since 2010, and there's a lot of other places around the world that do this as well at a much higher capacity than we do, but this is just an example of something that I know to give. We cryopreserve gonadal tissue for a patient's own future use because we do know that there are potential premature ovarian insufficiency effects later on, and we want to be able to preserve this tissue. And so we have it for pre- and post-pubertal individuals, and this is just some of the criteria that would allow them to qualify for our study. And so what we do is ovarian tissue cryopreservation with unilateral oophorectomy, and we do this because we know from decades of animal studies and because a study with about 20,000 Norwegian women that the remaining ovary maybe compensates and maintains the same level of hormones or similar levels of hormones, and that there is little difference in the age of menopause from women who have had unilateral oophorectomy for other indications. The remaining ovary also can release more eggs when stimulated for assisted reproductive technologies. And so what we do is we remove the ovary with laparoscopic technique and cryopreserve the strips. And re-implantation of these strips, as I'm sure Sherm will go into much more detail here, then here has resulted in ovarian tissue restoring fertility and hormone function. There's been over 130 reported live births. We know that there's been many more than that, but that's what's been reported in the literature. There's hormone production for up to 12 years with an average of 2 to 5 years. And there's however, the inherent risk that there's a possibility of reintroducing cancer cells. And this is specifically the case for some pediatric cancer patients that have leukemias or liquid cancers or metastatic disease. And so we need to improve a transplant and in vitro maturation to restore function for long term in our patients. And so women at any age, even those that are postmenopausal, have at least some of these early primordial follicles, which is referred as the ovarian reserve before in that graph. And we isolate this tissue in girls prior to this treatment, and so that we can cryopreserve it for later use. And the idea would be to isolate the desired cells, removing some of the cancer cells, or all of the cancer cells, and just isolating the cells that we want, and maintaining that follicle spherical shape and the interaction between the support granulosa cells and the oocyte, and then create a support structure that could then be re-implanted in that same way that has been successful for so many pregnancies. And so there's been a lot of, several labs that have used materials like collagen and plasma clots to encapsulate ovarian follicles, and this is just some examples of the collagen encapsulated preantral follicles that resulted in embryos after stimulation and IVF because it was done underneath the kidney capsule, and then a fibrin VEGF encapsulated ovarian tissue piece or primordial follicles that were done within the bursa and resulted in live pups. But when we looked at this, we wanted to think of some goals for improvement, including human scale and ability to promote vascularization at scale and compartmentalization. This is specifically an interest of mine because the small reserve follicles do stay away from the large growing follicles or organized in that way in the ovary. And we know that the ovary is compartmentalized in this way with a more rigid outer cortex where the follicle reserve resides, and there's a more pliable medulla where the growing follicles can expand and grow and recruit vessels. And so through the physical palpitations and through in vivo multimodal magnetic resonance elastography, shown here, we understand that the PCOS ovaries, for example, are much more stiff, and we hypothesize that this, at least in part, causes the anovulatory and increased number of primordial follicles, which is a characteristic of the PCOS phenotype. And alternatively, we hypothesize that the less rigid, or the reduction in relative stiffness of this cortex might result in premature ovarian failure or increased recruitment, which has been seen with cutting of strips and disrupting that extracellular matrix. And so because we know that this extracellular matrix might not only just have some physical properties, but also some biological receptors that might be important for follicles, our first idea for engineering an ovary was to decellularize the native tissue. And so this is a decellularized bovine ovary, bisected, and you can see the large follicles here, but you can also see how much of that ovary is actually extracellular matrix. And so we used slices of the decellularized material and cultured primary ovarian cells on these scaffolds. But what happened was it was mostly populated by granulosa cells, and which behaved normally, produced secretory blebs and produced estradiol that was secreted into the media and developed these follicle-like pores on top of the scaffold. And when we transplanted it, there was the ability to support some follicular genesis. We were able to initiate puberty with these, so they acted well as a hormone restoration, but it was very inefficient as far as having follicles grow in the normal way. And so we thought we would design or create a pore structure that was similar to this, but easier to seed the follicles in their three-dimensional spherical shape, maintaining those granulosa cell connections or support cells with the oocyte in the center. And so we started with gelatin as our base, and it's just kind of proof of concept for designing kind of the scaffold architecture. And so we tested a lot of different pore sizes by varying the strut differences in distance. And so, of course, when you 3D print, this is what the follicle would kind of feel within this scaffolding if the pore size was too small or if the pore size was too big. And so we down selected and created about 250 micron pores for a 200 micron diameter follicle, which was the mouse secondary to start. And so we tested at this point some different advancing angles. We had several architectures and strut distances and thicknesses, but we wanted to investigate these 30 degree, 60 degree, and 90 degree angles more specifically. And so when we seeded isolated murine secondary follicles, as you can see here, we realized really quickly that when the follicles were able to grow but also were snug within the scaffold over the course of the 8-day culture for the in vitro maturation, they were able to survive for the duration. And so the 30 and 60 degree angle scaffolds, there was about an 80% survival rate, where it was about 50-50 in the 90 degree through pore. And I'm showing this from our supplemental materials because I think it's really interesting that the area or the distance of cellular connection to the strut scaffolds was the same overall if you added them all up. But if they were touching three struts, that was spread over the three different struts instead of spreading over just one area. And so it kind of talks about or investigates some of the three-dimensional spherical biology of these follicles within materials. And so we know that they interacted with it and that they had healthy oocytes that were maintained, as you can see with this sliced image here. And this is just to summarize that the follicles reside in the middle of the pores and that the didn't have a very good success rate of survival, but the follicles that reside in the corners were able to attach and adhere. And so we were able to mature these follicles in vitro into eggs and into MT2 eggs with HCG. And so, of course, this demonstrates for the first time that follicles can mature and ovulate M2 eggs through an engineered scaffold and be released without any mechanical or enzymatic digestion. And so, of course, the next step was to transplant this into the ovarian bursa. So both ovaries were removed from adult mice, and the rest of the reproductive tract remains intact, and the 3D printed scaffolds were seeded with follicles. And so these bioprostheses supported follicular genesis as both large and small follicles that were seeded in these scaffolds were present after 8 weeks post-surgery. The corpus luteum are visible here, indicating that follicles have ovulated, and there's vessels that infiltrated within the scaffolds with blood cells as seen in this transplant. So we used PCAM, which is a platelet endothelial cell adhesion molecule, to show that there was a vessel filtration and angiogenesis without the addition of angiogenic markers. This is relying on the natural growth of the large antral follicles and their own angiogenic properties. And we tested AMH and inhibin A in the serum to identify that these vessels were functional and that indeed there was circulating peptide hormones within these females. And so we then repeated this with green fluorescent protein tagged follicles in the 3D printed scaffolds, and you can see that it's within a bursa of a mouse that does not express the green fluorescent protein, because you can see the oviduct here. You could see that after 11 weeks in this case, there were vessel formation through the scaffolds, and then after being mated naturally, these pups were born from the GFP follicles that resided within the 3D printed scaffold. And while those litter sizes were small, those pups went on, both males and females born from this method, to have normal litter sizes and grand pups of this original bioprosthetic ovary. So I want to talk about some of the next steps and why I think this 3D printing model is useful. And it gets down to compartmentalization. And so, again, we know that the cortex and the medulla have different organization and some different extracellular matrix proteins that might be clues into how follicular genesis is regulated. And so we can see that very easily with some of the scanning electron microscopy images here with the collagen bundles that I've pointed out with arrows that are tightly organized, whereas in the medulla there's fibronectin fibers that are less organized. And so I think some of these methods can help us define, really test some of our hypotheses about compartmentalization. And the next steps that I'm pursuing in my lab is to define the differences between the cortex and medulla extracellular matrix, and to observe follicular genesis under altered condition, to modify these inks and scaffold designs to achieve the desired outcomes. And some of what we're doing is to slice through decellularized tissue in different orientations to kind of develop a matrisome map. And some of our preliminary results have identified, a significant amount of collagens, which is what we've all know, but at different degrees within the different regions of the ovary, which is fascinating. And so we have some also ECM-associated proteins that we're looking into. And another thing that we could do with 3D printing is to print different support cells, so changing what the biology of the scaffolds with different structural proteins and different rigidity properties. And so I hope to be able to present some of that research in upcoming meetings. And with that, I would like to thank the audience for listening. Thank you very much.